Dear Chairman, respected colleagues, thank you very much for the honor of presenting in this conference and following Dr. Pibarot in his previous lecture, which is truly amazing. We're going to be discussing the next 10 minutes about some of the insights about imaging during transcatheter edge-to-edge repair. We've come a long way since the introduction of TEER many years ago with the introduction of next generation devices like the Gen 4 MitraClip and the Pascal devices, multiple device iterations in sizes and lengths, as we saw very nicely before. I mean, also for the Pascal device, two major iterations, the Pascal and Pascal Ace, which allow us to tailor our therapy to the individual patient. In particular, also imaging has evolved tremendously over the past few years, especially with novel 3D and 4D modalities, as we will see shortly. This allows us to plan our procedures very carefully before we start, in a way similar to how we plan TAVI using CT. We plan TEER using our echo images. And one of the basic modalities is biplane imaging with orthogonal 90-degree angulations, which has worked very well at the center of the valve, A2P2 area, very nice to see. However, it's important to know that when we discuss about edge-to-edge repair, that when we talk about the implanting a device at the center, we need an orientation of B12.6, and usually we see that very nicely in a long axis view that's about 120 to 160 degrees. If we talk about medial position for the device, then we talk about a counterclock rotation of the device and usually long axis views of 100 to 130. And if we go for lateral commissure implantations, usually we use angulations in the long axis view of 150 to 180. This also evolution of biplane imaging to include non-orthogonal angulations has helped us tremendously in this respect, in a way that we can now visualize the medial and lateral commissures more accurately. In addition to transillumination imaging, as we saw before, gives us a very nice rendering of the valve and improves understanding of the leaflets. Also, transillumination with transparency helps us a lot to understand where the pathology of the mitral valve is, and in particular for color, where it originates. The big evolution also in imaging is real-time multiplanary constructions, which we use heavily in our procedures, where we get a 3D volume and analyze it to a commissural long axis and short axis view. This allows us to very accurately identify the leaflets and the morphology of the valve. So overall, the screening for mitral regurgitation with TEER involves all these questions that we need to answer for mechanism, severity, jet location, leaflet morphology, leaflet length, very importantly, and mitral valve area. I'm going to show you 2 or 3 examples of how we apply all these in clinical practice. This is a patient referred to us for treatment of severe functional mitral regurgitation. Interrogation of the valve with biplane imaging and color at the same time helps us understand the extent of the regurgitant jet. Initially, we thought it was mostly confined to the lateral aspect of the valve. However, when we go into more careful imaging, we see that actually can extend all across the coaptation zone, maybe with a preponderance on the lateral side. So here 3D imaging is very important as well to understand the morphology of the leaflets, but multiplanary reconstructions here help us a lot to have a baseline understanding of the valve leaflets. Here we are positioning in the middle of the valve, A2P2, and we can clearly identify the leaflets, the leaflet length, morphology, and everything else that we need to understand clearly. This is the medial commissure. You see on the right upper hand image the grasping view in the medial commissure. We're not going to be working in this, obviously. And lateral, where we had the most jet from the beginning, this is how the morphology of the valve looks in the right upper hand image. Superimposing color also helps us understand exactly the location that we need to target with our devices. So in planning for TEER, for this particular patient, we opted for a single Pascal P10 in this location on the lateral side, and next to it, depending, an ACE device to supplement for any residual MR. Using fusion imaging helps us a lot in terms of transeptal and gives us a good understanding, especially when we have lots of wires on the right side that we want to navigate around so we don't dislodge anything. Also, biplane imaging with non-orthogonal biplane imaging helps us a lot to simultaneously project the short axis image as well as the bicaval view. And help us guide us. And in addition, the 3D rendering of the unfast view of the septal of the fossa ovalis helps us understand the morphology of the fossa ovalis and how we should, where we are entering the fossa ovalis into the left atrium. The guide insertion can be seen very nicely with fusion imaging as well. And in addition, we're always try to pinpoint the exact point of entry, so we can have that as a reference during our procedure, especially with Pascal. The edge of the guide sheet is not as clearly seen as with the mitral clip, so we have to use that as well. Introducing the device into the left atrium, we use 3D imaging to help us navigate. And moving over to the mitral valve and understanding position and trajectory is very important in order to have the correct engagement with the valve. Clocking is the next critical component of the imaging, and we want to clock the device to be perpendicular to the coaptation zone that we're interested in. Multiplanar reconstructions also help us a lot in to get all this information in one setting without the need to go back and forth with 3D and 2D imaging. And there's multiple advantages in this. However, disadvantages include the low spatial and temporal resolution and the difficulty in obtaining multiple acquisitions when we want to review our clasping sequences. Here we have the engagement of the valve leaflets. In this particular case, we did independent grasping of the anterior leaflet first, followed by independent grasping of the posterior leaflet with the Pascal P10. Optimization of the posterior leaflet, which is something that we usually do very often, depending on our initial results with color, and further optimization with of the anterior leaflet, as you can see here. The goal is always to try and get the best result with the first device, with a single device as possible, and use a second device only as needed. Leaflet insertion evaluation depends heavily on reviewing our clasping sequences and our biplane scanning and M-TEER scanning. This is an initial appearance after the first device. The color seems to be very nicely reduced. We have color only from one side of the device. This is a good reduction before deploying this first device. We could live with this color if we could not put a second device, but obviously we will try to get a second device in. Get it right next to the first device very carefully, optimizing the leaflets. And this is our final result. An evaluation of the MR reduction is performed primarily with qualitative measures, viewing the color. We can also assess ERO, vena contracta area, and indirect measures like pulmonary vein flow and LA hemodynamics, and also assess mitral valve orifice area by 3D planimetry. In addition, we have to point out that there are some data of an annuloplasty effect, an indirect annuloplasty effect of the edge-to-edge repair that we can also see here in this particular patient, a reduction in the posterior anterior diameter of the valve. A second case that sort of highlights the role of multiplanar reconstructions in creating a long axis view that is a grasping view as we would like it to see in the particular area that we're interested in which we can guide our device nicely in this view, and then go with the 2D biplane imaging for grasping. This is an XTW device for this patient with severe functional MR, followed by a second device in the center, an NT device with an optimal result. And this last case I wanted to show you is because of the complexity that it shows in the beginning and how you can go through and clarify things. The initial image on the left side looks very complicated, what we're going to do. However, when we sort of go into live 3D and live 3D imaging with color, we can see that most of the jet lies in the lateral A1, P1 area of the valve. Biplane imaging in this area didn't help us significantly, so we went with M-TEER. M-TEER in this lateral area shows clearly in the left upper in this part of the image on the left upper part, the flailing of the anterior leaflet, creating severe eccentric regurgitation. And this is obviously our target for a device. Photorealistic imaging and transillumination also help us understand the flailing segment in the lateral commissure. So this would be our plan, to put one device, a Pascal ACE in this particular patient in this configuration. Again, M-TEER for guiding the positioning over the valve with color also to navigate. We use long axis images at about 170 for good delineation of the device and optimization of both posterior and anterior leaflets to ensure maximal leaflet insertion before closing the device. And this is the final result with a single Pascal ACE in the lateral commissure with a single orifice valve and a fine result. A small iatrogenic ASD is commonly seen after these procedures. However, sometimes they can be large and significant, in which case closure devices might be indicated. So keep that in mind always to assess the ASD at the end. Finally, just a quick word on intracardiac echo, which is coming into play. This is our initial experience with 3D echo intracardiac for the mitral valve. In this patient, we can see a good delineation of the mitral valve leaflets. So it's a modality that's here, and we're going to be seeing more and more of this in the future. There, at this point, is complementary to standard transesophageal echo. However, there are case reports and evolving understanding of how we can use intracardiac echo as a sole imaging device for edge-to-edge repair. In summary, imaging with echocardiography has advanced significantly and offers important tools that help planning of the procedures in great detail. Intraoperative guidance with 3D and M-TEER imaging streamline the procedure and improve accuracy and efficiency. And we will see more in the near future with intracardiac echo that will play a significant role in these procedures. And with that, I would like to thank you very much for your attention.
Thank you, Dr. Chrissoheris, for the marvelous presentation. So our next speaker will be Professor Kasel, head of the Structural Heart Department.